Sports Medicine Case Series, Episode 11, Shortness of Breath with the Exercise. 16-year-old female athlete was referred to the pulmonary clinic with dyspnea on exertion as a chief complaint. She reported a 5-month history of dyspnea on exertion, particularly with exercise. She was a professional tennis player. She had no history of smoking, no cough, no chest pain. On examination, there was no respiratory distress. Her vital signs were normal with a blood pressure of 110/70, a pulse of 70, respiratory rate of 12. Her arterial saturation on oxygen and room air was 97%, body mass index of 25 kilograms per meter square. Chest examination was normal. All other examination results were unremarkable. A complete blood count, a thyroid function test, and electrolytes were all within normal range. A chest x-ray was normal. She underwent standard pulmonary function tests with normal results. With that, I came up with a few things on my differential diagnosis. Number one, exercise-induced asthma, structural cardiac abnormalities, hemoglobinopathies, vitamin deficiencies. Additional clinical evaluation was performed due to dyspnea on exercise. A eucapnic voluntary hyperventilation test was done, which was normal. I had to look this up, but a eucapnic voluntary hyperventilation test is a bronchoprovocation test used to diagnose exercise-induced bronchoconstriction. She subsequently underwent cardiopulmonary exercise testing by bicycle. This test was conducted by having her start at 60 repetitions per minute for 3 minutes, and then a load was added at 17 watts per minute until she fatigued. Her peak VO2 was predicted to be 2.1, but by their measurement was 1.48 liters per minute, which represented 68% of her predicted maximum. There were no EKG changes during her cardiopulmonary exercise test. Upon completion of this test, the authors suspected that she had a myopathy. Further testing was completed, including an ABG test, CPK, LDH, EMG, and a PEMX test were within normal range. She had a vitamin D. Her vitamin D test was 7 milligrams per milliliter. PEMX test is an acronym that stands for maximal expiratory pressure. It is a test of respiratory muscle strength, and it is used to assess respiratory muscle involvement in myopathies, which would include inflammatory myopathies, muscular dystrophies, or mitochondrial disorders, where respiratory muscle weakness can occur. I'd like to recognize the authors here. This was published in Case Reports in Clinical Practice in 2018, Dr. Rahimi and Dr. Edalatifard. Dr. Edalatifard. I'm Scott Hall, primary care sports medicine physician at the University of Utah, and I'm retaking my sports medicine recertification exam in 2026. I'm studying by going through a series of case reports and hope you'll join me on the journey and learn something along the way. This podcast is for educational purposes only. After vitamin D deficiency was identified, she received 50,000 international units of supplemental vitamin D every week for 8 weeks. After treatment with supplemental vitamin D, her vitamin D level increased to 31 milligrams per milliliter, and repeat cardiopulmonary testing revealed a peak VO2 1.95, which was 89%, and she reported resolution of symptoms. The ultimate diagnosis was a deficiency of vitamin D. A couple of key takeaways. Number one, bone and musculoskeletal health are fundamental roles of vitamin D through calcium and phosphorus regulation. Studies have documented associations between adequate vitamin D status and reduced risk of stress fractures and improved injury prevention. The vitamin D receptor is present in skeletal muscle tissue, where vitamin D may influence muscle metabolic function, type 2 muscle fiber size, and neuromuscular function. Pearl number 2. The American College of Sports Medicine states that current data do not support vitamin D as an ergogenic aid for athletes with adequate status. Clinical pearl number 3. Vitamin D deficiency is common among athletes, particularly those in northern latitudes, training indoors, darker skin complexions, or training early morning or evening hours when UVB exposure is low. The prevalence of vitamin D concentrations below 50 is high across various sports, especially during winter months. So the big question in this case was, what was the cause of the vitamin D deficiency? My educated guess is insufficient sun exposure. I make that guess because this study was published out of physicians who were practicing in Iran, and I'm guessing that this young athlete may not have had enough sun exposure due to covering. That's purely a guess. Low dietary intake may be another reason. Vitamin D is naturally present in a few foods, mainly oily fish, egg yolks, and fortified dairy products. Athletes with restrictive diets, veganism, or limited dairy consumption may have inadequate intake. Another potential reason is malabsorption disorders such as celiac disease, which can cause vitamin D deficiency through impaired intestinal absorption. Celiac disease presents with nutritional deficiencies, including vitamin D, and athletes may have non-classical presentations with fatigue, iron deficiency, or subtle GI symptoms. Obesity could be another cause. In our case, this athlete had a normal body mass index, but obesity or higher body fat percentage leads to sequestration of vitamin D in adipose tissue, reducing bioavailability. Athletes with obesity has 2 to 3-fold higher prevalence of vitamin D levels below 20 compared to those without obesity. Another rare but potential cause is genetic polymorphisms in vitamin D binding protein or metabolizing enzymes, which can predispose to deficiency. So I've got a couple test questions for you. Question 1. A 22-year-old elite gymnast training indoors in Boston presents for routine screening. Which of the following factors places her at highest risk for vitamin D deficiency? A. High dietary calcium intake. B. Training latitude greater than 35 degrees north compared with indoor training. C. Type 1 muscle fiber predominance. D. High aerobic training volume. E. Elevated resting metabolic rate. The answer is B, training latitude. So it has been studied, and athletes training at latitudes greater than 35 degrees north or predominantly indoors are at higher risk for vitamin D insufficiency and deficiency. Next question. An NCAA Division I swimmer has a baseline vitamin D level of 45 in October. What daily supplementation dose has been shown to achieve and maintain vitamin D sufficiency over a 6-month winter period? A. 400 international units. B. 1,000 international units. C. 2,000 international units. D. 4,000 international units. And E. 10,000 international units. The answer is D. Studies show that athletes starting at adequate levels who receive 4,000 international units maintain sufficient status over 6 months when compared with those on placebo. Next question. According to the American College of Sports Medicine, which athlete requires vitamin D assessment? A. All college athletes at pre-participation examination. B. Athletes with a history of stress fracture and muscle weakness. C. Only athletes with documented osteoporosis. D. Athletes competing in outdoor sports exclusively. E. Athletes over age 40. The answer is B. Athletes with a history of stress fracture and muscle weakness. Next question. A study of Polish elite athletes found what percentage had inadequate vitamin D status, less than 30, during winter months? A. 25% of outdoor athletes and 30% of indoor athletes. B. 45% of outdoor athletes and 50% of indoor athletes. C. 60% of outdoor athletes and 70% of indoor athletes. E. 95% of outdoor athletes and 98% of indoor athletes. The answer was D. There was a study of Polish athletes that revealed 80% of outdoor athletes and 84% of indoor athletes had inadequate vitamin D status during the winter months. During the summer months, the outdoor athletes improved to 42% with inadequate status, while indoor athletes remained high at 83%. Thank you.